Welcome back, everyone. It is my privilege to introduce our next speaker today, Dr. Chad Eldridge. With over 25 years of experience as a nurse, Dr. Eldridge's career spans critical care, emergency medicine, and hospital leadership, providing him with a comprehensive understanding of healthcare systems and patient care. Dr. Eldridge's dedication to advancing his field led him to obtain a doctorate of nursing practice degree from the University of Kentucky, focusing on executive leadership in healthcare and health systems. Currently, he serves as the state's HAI outbreak lead in the Healthcare Associated Infection Antibiotic Resistant Prevention Program at the Kentucky Department for Public Health. His expertise in infection prevention and leadership in healthcare systems makes Dr. Eldridge an invaluable asset to our boot camp today. At this time, I will stop sharing my screen and welcome to Dr. Eldridge as we delve into strategies to manage outbreaks.
All right. Thank you so much for that introduction. Can everyone hear me?
Yes, we can hear you.
Okay, so I'm going to start sharing my screen and we'll jump right in. So you see my screen okay?
Yes, we can. Thank you.
Okay, awesome. So as she said, I am Chad Eldridge. I am the HAI outbreak lead. And today we're going to discuss outbreak investigation and management. So if you come across an outbreak or the need for an outbreak investigation, more than likely you'll be hearing from me. Certainly you'll be hearing from my team. So here's just our learning outline for today. We're going to look at our program overview really quick. We're going to define an outbreak. We're going to look at what is the alphabet soup of infection prevention and control. We're going to dig a little deeper and dive into the meat and potatoes of some details of outbreak investigation and look at those fundamentals. And then we'll talk about knowledge as a gift to us, and then we'll discuss that company might be coming. So be ready. So hopefully, here's some learning objectives. I don't have to read these word for word to you, but hopefully you get an overarching sense of what we're talking about. CROs, CREs, MDROs, that's that alphabet soup I was talking about. We're going to discuss a little bit about reporting requirements for the state, especially as related to CROs and MDROs. And then we'll certainly discuss those key elements of an outbreak investigation and response. So first of all, our program is the HAI-AR Prevention Program, which stands for the Healthcare Associated Infection Antibiotic Resistance Prevention Program. And Andrea Flincham, who many of you know, she's our manager. I serve as the outbreak lead, and then we have Michael Curran, who serves as our prevention lead. And then we are very fortunate to have 10 RIPs, which I think Ruth will be talking about in more detail later. But what RIPs are regional infection preventionists from our program. So we've divided the state into 10 regions. Each region has an infection preventionist from our program. And they're great to work with on my side, and I know that I've heard from many facilities who have worked with our RIPs that have benefited from their expertise. So if you don't know who that person is in your area, please reach out to them. Ruth will give you some more detail on how to do that later, I think. So what we do is our goal is to eliminate healthcare associated infections in Kentucky. To help you do that, and certainly, we do that to protect our patient population. When we get involved, there are multiple ways we might get involved. We may get alerts from our regional labs. The facility lab results may come into us per the regulation, and we'll get involved in that way. You may alert us to an outbreak. or sometimes just facilities call us with questions, and you're welcome to do that at any time. We are non-regulatory, and we exist 100% to help you. So, and we're happy to do that. So, and once again, where we work, some of us are central staff located in Frankfurt, and then the regional IPs are all across the state. So, how we can help you? We help with calls, visits. We can answer questions, provide guidance. Again, non-regulatory. So if you ever wanted to have a guest come in um, uh, to help, we're the ones, and it's there's no charge to our services either to you. So we can. It's kind of a double whammy. We can help you, and it's not going to cost you anything. So just real quick, we are CDC grant funded, so services to you are free, but those are provided through the CDC. So we use our CDC lab for surveillance, and none of that comes at a cost to the facility. So if needed to do a point prevalence survey, we will ship you the swabs and everything you need. You will ship that back overnight to our regional lab, and the testing will be performed, and again, all at no cost to you. I just wanted to highlight, I know there's a lot of long-term care facilities represented on the call, or on this call, I guess is what it is, Zoom. So I think there are probably multiple references to us, but I know this one in particular, the QSO-20-03, that's CMS basically endorsing our program, and that was them. We have HAI programs in every state and in Puerto Rico and the Virgin Islands. And so CMS just said, hey, in addition to the CDC, these guys are great resources in your state. Use them. And so some of you may have never heard of us, but we certainly get that endorsement from CMS and others. And then we're a part of the Kentucky Department for Public Health. So we're in the infectious disease branch in the Division of Epidemiology and Health Planning. So these are some of our other program concerns, besides MDROs that we'll talk about today, and CROs that we'll talk about today. So CRS, certainly many of you may have heard from our program concerning Candida auris. We look at VRSA and VISA, which is vancomycin resistant Staph aureus, or vancomycin intermediate Staph aureus. Any non-CRO outbreaks, we look into pseudo outbreaks, and right now we're doing a lot of Legionella investigations. So we become involved in a lot of these, in addition to the focus of this talk today. So in general, this is an overview of outbreak investigation and response steps. These won't always occur in a linear fashion. In other words, not every outbreak will follow the order seen here, and some outbreaks might have a couple more steps, some less. And we're going to do our best to touch on many of these steps today. But given the audience, and I know that the prevention staff across the state, we're going to need to make some necessary detours and pit stops. It's really important to understand the system that we're dealing with. And so, as with any system, like a circulatory system or a system of a car or whatever, the better you understand the system as a whole, the more you understand the individual components that make up the system. And in the same token, the better you understand those individual components that make up the system, the more you'll understand the system as a whole. So we're going to look at outbreak management sort of from a system standpoint. We want to understand the system, and we want to understand those components that make up the system. And certainly when you understand those, hopefully we can prevent outbreaks before they occur. But if not, that'll help us. Understanding that system and those components will help us respond appropriately if an outbreak or an investigation does occur. I just want to make a quick note on collection, organization, and analysis of data. Keep good notes. I've seen some note taking in facilities I go to, and uh, many of you are off to a very good start. But you want to know, for example, with carbapenem-resistant organisms, where that patient location was, so you can track, the location of the different patients. Certainly, what the organism is specifically, and what the mechanism associated with that organism is, which we'll jump into that later in terms of what that means, an organism and a mechanism, and then the specimen source. So I've seen a lot of note takers. They say, well, we've had, 10 UTIs, and they track them just simply as a UTI, or we've had 12 wound infections. But I recommend, certainly that's important, but making that a little more robust, and knowing that patient location and certainly the organism, because what might seem to be an outbreak, or what might seem to be um, an issue, we could be dealing with different organisms. So just keep that in mind. Okay. So first of all, what is an outbreak? So our regulation, and if you're not familiar with our regulation, that's basically our state law for reporting, is our reporting regulation. There's a link there in my um, slide, and we will get you the link to that slide if it's not working today. But an outbreak is two or more cases, including healthcare associated infections, that are epidemiologically linked or connected by person, place, or time, or a single case of an HAI not commonly diagnosed. So, well, what does that mean? Well, first thing that I want you to understand, certainly when we get involved from the state, from the HAI program, is our outbreak investigations are never finger pointing exercises. Okay. A lot of people, when we call and we start to ask questions, um, I think it's natural to kind of get defensive and like, well, this isn't our fault, and we're not into placing blame. We're not into finding fault. We want to identify any gaps, any potential cause for harm to individuals, and close those gaps. So we're never looking to point fingers that, oh, this is your fault or this is someone else's fault. Examples of single cases of HAIs that aren't commonly diagnosed may depend on your location. Certainly throughout the state, again, we'll talk about carbapenemase producers in a little while, the same thing as a mechanism, but NDM, VIM, OXA23, those are examples of specimen or items that may not be common in your area of the state. So just one of those will cause us to sort of take pause and have an investigation. Those are very, very mean things that we'll discuss later, and it's not something you want running around in your facility. Right now, they're pretty well, depending on the area of the state, they're rare, and we want to keep it that way. And so when we hear about these things, we will be contacting you. And if you hear about them, certainly contact us so we can help you lock them down. So again, I know that this is a review for many of you, and for many of you, this is going to be the first time you see some of this stuff, or you'll have heard of this stuff and really not not have understood what we're talking about. So because there are a lot of new IPs, because there's a lot of turnover, and no one ever takes the time to explain this stuff, I want to make sure that we have a good foundation. So we're going to talk about IPC alphabet soup. So we're going to talk about the ABCs of CROs. We're going to do an overview of CROs, which CRO stands for carbapenem-resistant organisms. And then we're going to look at some common but often misunderstood vocabulary. Again, this is a judgment-free zone, okay? I already know that there's many of you who have not heard of this, and we want to get you up to speed, and so that way when our office calls you, you know at least somewhat what we're talking about. And if you don't have a firm grasp, then we'll certainly re-explain it, because again, we're here to help, and we want you to understand what's going on. So we'll start with carbapenems. What are carbapenems? So carbapenems are these broad spectrum antibiotics of last resort, you know, quote unquote. As ESBLs began to emerge and spread, they became carbapenems became certainly more important. And in the United States, we have 4 approved carbapenems: so imipenem, meropenem, doropenem, and ertapenem. And ertapenem is known to be less active against some bacteria, so it doesn't cover Pseudomonas, for example. So, you know, it becomes easy to see why carbapenem resistance is so concerning, and can be, and begin to understand why you don't want these organisms running around silently in your patient population. Because if these are the antibiotics of last resort, and we build carbapenem resistance, naturally you're going to have less effective means to treat these infections, and your morbidity rates are going to climb. So that's why certainly it's important. So here's our first course, our alphabet soup. And again, this might be a review to you, and you might be understanding for the first time what some of these acronyms mean. So IPC, Infection Prevention and Control; HAI, Healthcare Associated Infection. I don't have to read all of these to you, and most of these you probably know and understand. But if we talk about AR, antibiotic resistance; POA, present on admission. And we may see, speaking of present on admission, speaking of not pointing fingers, we know that if an organism comes in and you've tested for it on admission, and that organism is present on admission, certainly you didn't give that person, or that person didn't obtain that organism at your facility because it was there when they got to the doors. But depending on the organism, we still may want to say, hey, let's look into this at your facility to make sure that this organism doesn't bust loose at your facility and spread and cause undue harm. Okay. And these are many of the HAI concerns. So this is kind of a review of our Kentucky alphabet soup. So when we talk about MDROs, or multi-drug resistant organisms, that's a very large umbrella term. So that's really any organism that's resistant to multiple drugs. We talked about what a carbapenem is. It's that antibiotic. So then when you talk about CROs, those are specifically organisms that are resistant to carbapenems. Again, sort of a broad umbrella, because there are many more details that can be found as a CRO. For example, a CRE is a CRO, but it's more specific. It tells you that it's a carbapenem-resistant Enterobacteriales, a carbapenem-resistant Acinetobacter baumannii, or crab is even more specific. So that is an Acinetobacter baumannii that's carbapenem resistant, and then the same with Pseudomonas. And so you can also see that a lot of this is a mouthful. So when we call you to talk about carbapenem-resistant Acinetobacter baumannii, it's hard to say that 5 times fast. It's hard to say it 1 time fast, so we call it crab. Same with CRE. So we use these really to make it easier to talk about, but we also find that when we talk about them, people don't know in detail really what we're talking about. So point prevalence survey is a PPS. We'll talk about those in detail later. And then anytime we say CP, we're talking about a carbapenemase producer. And so some synonyms of CP would be a mechanism or a carbapenemase gene. So we could say that an organism is a carbapenemase producer, which means it creates a substance that makes the organism resistant. It essentially melts the antibiotics that we send at it. So we could say that an organism is a carbapenemase producer. We could say that it has a carbapenemase gene, or we could say that it has a mechanism. All those kind of mean the same things. So we talked about CRE. So these are examples of enterobacteriales. And when these become resistant to carbapenems, any of these would be CRE. So these are enterobacteriales like E. coli, Klebsiella pneumonia, or Oxytoca. And so on their own, they're enterobacteriales. When any of these become resistant to carbapenems, now any of these could be called a CRE. Again, I want to point out the distinction of KPC. A Klebsiella pneumoniae is different from a KPC. What KPC stands for is Klebsiella pneumoniae carbapenemase, which actually in about 1999, we found the very first carbapenemase gene. And where did we find it? We found it on a Klebsiella pneumoniae. So what do you name the first gene that you find on an organism? Well, you name it after the organism, which is kind of unfortunate now, because what we know now is that these guys can switch these genes up. So in other words, this Klebsiella pneumoniae that might have this gene, it can pass it to a Citrobacter, or it can pass it to a Proteus. And so now you could have a Proteus with a KPC, meaning that that Proteus has a carbapenemase producer, a carbapenemase producing gene. It has a gene, again, that creates a substance that melts the carbapenems that we send at it. So a little concerning, but I wanted to make that distinction for you. The other thing, when we're talking about melting antibiotics in these genes, you've heard me say before, if you've ever been in one of my talks, if I ever do get into research, one of the things I want to research is, do organisms laugh? Because I am almost certain that they do. They laugh, and they laugh at us, and they laugh at us when we send these antibiotics in to kill them, and they just melt them. And I think when they do it, they laugh. I'm almost certain of that. So we're going to talk about some classifications, and we're going to talk about understanding minimum inhibitory concentrations, and we're going to talk a little bit more about carbapenem resistance. So what is an MIC, or a minimum inhibitory concentration? That's the lowest concentration, and that's measured in mics per mil, micrograms per milliliter, of an antibiotic that inhibits the growth of a given strain of bacteria. An MIC helps determine which class of antibiotics is most effective, and this information can lead to an appropriate choice for an antibiotic that will increase the chances of treatment success and help the fight to slow antibiotic resistance. So that's where we see these MICs. We see, okay, is this organism susceptible to an antibiotic, or is it resistant to an antibiotic? So we're going to talk a little bit about microbes and why antibiotic resistance matters. So these increasing resistance levels, we'll talk about increasing mortality, which I've already touched on, colonization versus infection, carbapenem resistance, and then we'll touch a little more on carbapenemase genes. So, as if you've been in my talks, you've probably heard me say, who really needs a pandemic? This stuff is nuts. It's scary. We've got organisms that have genes that can, obliterate our antibiotics. And if that isn't bad enough, they can give it to their buddies. So, Klebsiella with a gene can be partying with a Citrobacter, and they say, hey, man, these antibiotics, it looks like they're really getting you down. You really could use something. Hey, I got this. Try this on. Take this gene, and then they pass it, and it's crazy and it's scary, and so we want to keep these things at bay, certainly. So again, just a little more detail, carbapenem resistant or carbapenemase producing organisms. They produce carbapenomases that are these enzymes that digest those antibiotics. They can be plasmid encoded, which means they can pass resistance between each other, even across class. And then, of course, many organisms produce a biofilm. Certainly, a lot of the organisms we deal with are water loving, so um, uh, and they just produce this biofilm that surrounds them that makes them more hardy in the environment, and it allows for more successful transportation to others or to the patient population. So um, again, I don't want to repeat myself if you've heard me speak before, but these organisms, let's take an OXA 23 on a carbapenem resistant Acinetobacter baumannii. You can set that organism on a bedside table. You set it on the bedside table, you walk away. It doesn't require anything else from you. You don't have to feed it, you don't have to water it, you don't have to talk to it. A year later or more, you can come back and someone can pick that up off of that table and spread it to a patient. And so they're very hardy, and these biofilms make them hardy. So it's concerning. So these are some examples of some carbapenemase producing genes. So we have the oxacillinases. These are often with, we'll see them associated with crab. So OXA 23, OXA 2440. And then we have the bottom four are typically more involved with CRE. So KPC, NDM, FIM, and IMP. And again, these are those carbapenemase genes or mechanisms. So if we called and said, hey, you had a CRE with a mechanism, or you had a CRE with an NDM, that means that it has that carbapenemase gene named MDM, and those are mean, and they don't like you, and they want to kill you, and they want to kill your family and all your friends. So beware of that. You will not be friends with these things. Really, really quick, the emergence of antimicrobial resistance on a like super simple level. You've got resistant bacteria over here on the left, and you got susceptible bacteria. Well, they come in contact with each other, and they can have this resistance gene transfer. So now, what was susceptible is now resistant because they say, "Hey, try this on for size." And also, just to point out that antimicrobial resistant strains, or excuse me, antimicrobial exposure can help resistant strains where the resistant strains are rare. It may be in a individual. Antimicrobial exposure can um, cause those resistant strains to become dominant. So, while we're talking about this, I just want to make you aware of sort of what I call the 5 levels of mean. All right, the 5 levels of nasty, the 5 levels of um, so we'll take Acinetobacter baumannii, for example. Acinetobacter baumannii is mean all by itself. You don't want this in your wound. You don't want this in your bloodstream. It would like nothing more than to kill you. I'm fairly certain, and it will. Um, so that's just Acinetobacter. When it then becomes carbapenem resistant, now it's even meaner because now it's resistant to those antibiotics that we had to treat it. Well, can it get any worse than that? Yes, it can, because then it can become a carbapenemase producing crab. So it can be a crab with OXA 23. So now it has a mechanism or a carbapenemase producer that melts the antibiotics. It couldn't possibly get worse, though. Well, yeah, actually it can, because you can have then crabs that are not susceptible. So, in other words, there's really no antibiotic on the market that it's susceptible to. They could be intermediate, though, meaning they kind of work, but not really. And you think, well, it really couldn't get any worse than that. Well, yeah, it can, because then you can have a crab, for example, that's pan-resistant, meaning it's resistant to every antibiotic on the market. And certainly the mortality rates go up with something like that. You really run out of treatment options. So why focus on antibiotic resistance? Um, Again, these are germs that are difficult to kill. So life-saving treatments depend on antibiotics that work. And second-line antibiotics can lead to more toxicity. And antibiotic resistance can affect all communities, and without action will get worse. So we've got to stop the spread of these organisms, certainly. Um, and again, the increased morbidity and mortality. So here are the current threats in the United States, and as per the CDC. And when you see threat level urgent, I don't know what your threat levels are in your own head, but urgent is the highest. Urgent, it doesn't get higher. It's red level. And so most everything I've talked about, you'll see, is in the urgent category. There's your Acinetobacter, your C. auris, your CRE. And so if, and this isn't even taking into account carbapentamases, this is just simply carbapenem resistant organisms or C. auris. So if you get a phone call from our program, more than likely it's urgent. So please try to take our call or call us back at your earliest convenience, because the stuff that we're going to get involved with is usually pretty nasty, and we want to help you um, lock it down. So again, antibiotic pressures, those are the most common predictors of antibiotic resistance, and device utilization. So, invasive devices, those provide entry into normally sterile body sites. And then biofilm can form on those central lines, urinary catheters. Um, and so when we start talking about outbreaks, the spread, how is this stuff spread? Well, it's most commonly spread with healthcare workers on their hands, on their scrubs, or on equipment. And so then, to reiterate, mobile equipment contamination, environmental contamination. Sometimes it can happen patient to patient. But one of the red flags I often hear when I'm talking to someone about spread, they'll say, "Well, we have a patient that is in their room and they never leave the room," and so they sort of write it off as it's not a big deal because this person never comes out of the room. Well, our concern is not the person coming out of the room. It's healthcare workers that spread the stuff. These organisms don't have wings, they don't have wheels, and they don't have really any other mode to get around, except for healthcare workers and mobile equipment. So it's very important to think about that in preventing outbreaks and in responding to outbreaks. So, and I can't stress enough the importance of environmental services. In our mind at the HAI program, they are infection prevention technicians. Okay, they are part of your frontline staff, infection preventionists, and so hopefully they're educated as such. Hopefully they know the importance of their role. And then certainly colonization can't be ignored. We're going to talk a little bit later about colonization versus infection. Um, uh, but colonization is thought of as the tip of the iceberg. Well, actually, it's not. Actually, colonization is the iceberg. If you're seeing a lot of, uh, if you're seeing infections, infections actually are only the tip of the iceberg. So if you see one or two infections of a certain organism, it's likely that you have a high colonization in your facility. And so we'll talk about how to discover that and what to do about that. So colonization versus infection. It's almost like I planned it like this. So what is the difference? So an infection obviously is an organism it might not be obvious. It's not obvious. That's why we're talking about it. But it's an organism on or in the body that actively causes illness. So pneumonia, urinary tract infection, wound infection. Colonization is organisms found on or in the body, but they're not causing symptoms or illness. It's important to stress that colonization does not mean the organism is dormant. It doesn't mean it's asleep. It doesn't mean that it can't cause harm. It just means it's not doing it currently. So certainly a person that's colonized with an organism, they can become infected with that organism, and that organism that an individual is colonized with can still be picked up by mobile equipment or healthcare worker and passed to the next person down the hall, or even multiple rooms down the hall. Okay. So, trick question, kind of a loaded question. How do we treat colonization? Well, we don't really. I mean, infections are treated, colonizations are contained. It's not recommended to treat colonizations of CRO with antibiotics, but we need to follow the recommendations to keep them from spreading. And so what we want to do is manage colonization. So PPS, when indicated, um, certainly is a hand washing, mobile equipment, everything we've talked about. So again, this is just some of the fundamentals that we already sort of touched on earlier of an outbreak investigation. So notification. I mean, again, sometimes you may notify us of an outbreak. Sometimes we might notify you if we get a carbapenemase producing uh, CRO, or we're going to reach out and say, hey, we found this mechanism. It's mean. Let's talk about it. Where do we go from here? And certainly we don't want any of you reporting simply for the sake of reporting. We have a regulation that says what to report and when to report, and we don't believe in you doing that just simply for the benefit of the paper. Uh, we have epidemiologists that when you submit EPID 250s and you submit different things to us, that look over that. And so sometimes in that investigate, or in that, you know, when our EPIs are looking at that, they may find a cluster, and they may say, hey, this is 2 or 3 or 4 individuals that have the same organism, maybe the same mechanism. They were in the same facility at the same time. Was this an outbreak? And so we'll present it back to you and say, you may not have been aware of this, but were you aware of this, and was this an outbreak? And you'll look into it and say, oh yeah, but we hadn't noticed that. Or no, all of these patients were never on the same unit. They weren't even in the same building or whatever. But we want to try to help you, and so we don't want you just reporting for the sake of reporting. We may find clusters that you weren't aware of because you guys are all busy. And then assessment. Certainly, we're going to talk about assessment, and we can help with that. The sooner, the better, so that we can help identify and close any gaps. And then we want to create sustainable changes in outbreak and response. Okay. Some people they say, hey, we're just going to put everybody in the whole facility in and contact precautions until this blows over. Well, that's not a sustainable change. And any issues that you had prior to doing that is going to come back when you change back. Always, you want to evaluate those changes, and those changes that work, you want to keep them. You want to keep them so you can prevent further spread. We've already said this, but you might tell us you got something going on. We might reach out to you on something that's going on. So let's talk a little bit about the regulation. Some of you may not know that there is a regulation, and what that means. So it plays an important part in epidemiology and public health. So we're going to touch on it really, really quick. Where you can find it, again, I don't know if this link is going to work in what you guys have. You can copy and paste it. If you ever get an email from me, it's in my signature. I've encouraged all of our staff to put it in their signature as well. So if you get something from us, and this one is always up to date. We used to find that, you know, we would say, hey, we would call someone and say, hey, did you do this or that? And they would say, well, the regulation doesn't say I have to. Well, they had a 20-year-old regulation or something. So this one's always up to date. And so let's all work off the same page. And so I would favorite that or something. So you always have access to it. Certainly you can download it as well. But if you have access to the link, you're always going to have the most up to date. And really, as far as our concerns are, there's three major sections. So section 3, it's a very long regulation. So that's why I'm going to give you some highlights here. Section 3 is about submission of specimens to our lab. There are requirements for that. Section 10 looks at multi-drug resistant organisms and other organisms that require routine notification. And so there's some details about that. And then section 11 is really where the bulk of our work comes in, and that's multi-drug resistant organisms that require priority reporting by EPID 250 um, uh, and through the Health Information Exchange within 1 business day. Okay, so this is the big 6 here. Candida auris, carbapenem-resistant Acinetobacter. Notice it's not crab because it's any Acinetobacter. It doesn't have to be Bomanii. And the same here. We usually say CRPA for carbapenem-resistant Pseudomonas aeruginosa, but it's really any resistant Pseudomonas. Most likely it's Bomanii and aeruginosa, but it doesn't have to be. And then here's this little asterisk down here at the bottom. The regulation defines the MIC value required for reporting. So it's important to know what those are, and we'll look at those here in just a minute. So this is just more detail in section 3. I'm sure you guys, don't want me to read this to you, but these are the highlights. I notice it goes at least to X, and it goes probably well beyond X. But for example, this is what's required to be submitted to our lab, CORIS, and the things that mentioned here. Okay. So, and it's important. These are required to be submitted by EPID 250 within a business day and submitted to the state lab. So it's also important that you guys start your response immediately. If you have a carbapenem-resistant Acinetobacter baumannii, a crab, and your lab finds that it's a crab, go ahead and put those people in transmission-based precautions, okay? Don't wait for anything from us because you're not really necessarily going to get anything from us. Now, on Acinetobacter, that will eventually make it to our regional lab, and I think we're going to give extra credit to anyone who doesn't work for our program that can tell us where our regional lab is located. I'll tell you later, but you guys can guess that in the chat. 2 points extra credit for anyone that gets it. But anyway, that will eventually, that will go to our state lab and then to our regional lab, which they're going to look for carbapenemase producers, the OXA23, the OXA2440. When we find that it has OXA23, OXA2440, which about 85% of Acinetobacter we found in the state do, so more than likely it's going to have it, then we'll reach out to you and say, hey, this crab also has, here's a little more detail for you. We also know that it has this carbapenemase gene called OXA23, but really you should already have started your response with that, putting them in precautions and whatnot. because to wait to hear back from us, there's really no reason for that because we're not going to confirm what you've sent us. If you say it's a CRE, it's a CRE, which we'll talk about. And so if it is a CRE, you need to get those precautions started immediately so that that doesn't spread. And this is interesting, and a lot of what a lot of people don't know, but our regulation actually gives it defines the MIC breakpoints for carbapenem resistance. So it'd be nice if your facility breakpoints would match these. If your facility breakpoints don't match these, you need to go by these in terms of reporting and submission. So again, Acinetobacter, it's resistant to imipenem, meropenem, or doropenem with an MIC greater than or equal to 8. And CRE, imipenem, meropenem, or doropenem MIC greater than 4, or ertapenem greater than or equal to 2. And both of these have a or identification of a carbapenemase. So even if they don't meet these MIC values, but they have a carbapenemase, then they're required. It's not likely to happen, but it could happen. And so you're going to send in your EPID 250s with your MIC values to us. Here's the secure fax for reporting. It's also in our signatures. And then what about reporting to the local health department? Well, I can't ask you not to do that, okay? They may want that information. Some local health departments want it, some don't. Really, you need to submit to us. So if you're faxing to the local health department, please, so that nothing falls through the cracks, fax to us on the same one. So really the priority is getting it to us. But you can put both our numbers in there and fax them at the same time if you want. But we get the priority, and if they want it, certainly send it there. And again, we do not do confirmatory testing. So if we don't run MICs at the state lab, in other words. So if your lab says, hey, this was a CRE with an MIC of 16 on a certain carbapenem, well, it's CRE. What we're looking for are those carbapenemase genes. All right, so the EPID 250 again, it's something that we've asked you guys to report to us, and we don't want you to do that just for the benefit of the paper and the pen. Okay, we want to be able to. We get a lot of information from these EPID 250s that help us with investigations, whether at your facility or at others. And so please try to complete them as much as possible, because a lot of the information for our investigations is important. So if it's not on the EPID 250, we may have to call you. And so if you fill it in completely, you may save a phone call. And in a lot of instances would save a phone call. And then again, about a note about facility tracking and documentation. Track the organisms, especially the ones found in the regulation. Track the room, the specimen source, and the name of the organism and mechanism if one is identified. So I'm going to give you guys a minute to think about this for a second. This is a conversation much like I have from facilities across the state. This happened to come in an email, but just take some time to think about this. If you have the regulation open to those MIC breakpoints, it will help. But this email says, I have a facility that has a resident with presumptive CRE. They came from somewhere, they are still waiting the results of the state lab to see whether or not it's CRE. And I've attached the lab result that they sent me. So what are your all's first thoughts about this email? And what are your thoughts about, and I guess you can put it in the chat or you can just think about it. What questions does this bring up? First of all, is this a CRE? Why or why not? What stands out to you about that question that they're posing? What should be done at this point, or what should have already been done? And, what can this misunderstanding of the process lead to? So just real quick, this is a CRE, and it's CRE for two reasons. Number one, because ertapenem is identified as greater than 1. And so per the regulation, equal to or greater than 2 is resistance. Well, because of doubling resistance, greater than 1 is 2. So another way of saying this ertapenem, and you'll notice they identified it as resistant, so that's accurate. So greater than 1 in this case is 2, so it's resistant to ertapenem. Also, you'll see that their meropenem, they mark it as susceptible, but according to the regulation, meropenem of greater than or equal to 4 is resistant. So it's also resistant based on the meropenem because it, so really for two reasons, this is a CRE, and we are not going to confirm that. And so they need to deal with it appropriately. The issues that can come here is that they're not, if they don't start the process of getting this person in precautions, then it can spread, and it can spread to someone and can be harmful to that person. So just those are just some things to think about there. So when they say they're waiting results from the state lab, well, that's an unnecessary delay. So here are your foundations of infection control, and I thought Dr. Glowitz did an awesome job of talking about hand hygiene. I hate really using IPC basics because it sounds so basic. These are foundational. If these are not firmly established in your infection control program, your infection control castle will crumble. So hand hygiene, personal protective equipment, cleaning and disinfection, and environmental cleaning and communication. I'm going to speed things up here a little bit. So response overview, we're going to talk about how to respond. Again, Dr. Glowitz talked about that culture of safety, compliance for everyone. That means for EVS, nurses, providers, even cardiologists, believe it or not, everyone needs to be in compliance because the MDRs, these multi-drug resistant organisms don't care. And there aren't people that are just blessed with a force field or they don't get that on graduation. So, you know, and having a culture that can say, hey, again, thank you for washing your hands, or politely ask, did you wash your hands? That's an amazing to have that culture, and I encourage leadership to try to provide that culture. Enhanced barrier precautions for long-term care facilities. There's going to be a talk on that later, and then you know, certainly a lot of this is basic infection control practices. As much as these things are mean and scary, and they hate you, there's nothing that can't be dealt with outside of basic infection control practices or foundational infection control practices. So there's no need to refuse someone with an MDRO or CRS or whatnot. So you want a cohort if possible. You want to put them in those transmission-based precautions, contact precautions, hand hygiene, environmental infection control, daily enhanced cleaning, mobile equipment cleaning, high-touch surface areas, and then competency assessments and adherence monitoring. So Dr. Glowitz mentioned it with hand hygiene, but it's also with adherence monitoring with EVS. It's adherence monitoring with PPE. And then the importance of communication both in within a facility and outside of the facility. There's so many times we hear of, and again, we're not pointing the finger, but we hear of facilities getting someone known to have something mean, but it was never told to them, or it wasn't told to them. Maybe they had to search for it in a chart, you know, 700-page chart. So it's hard for that next facility to do what's right if it's not adequately communicated. And when we come in, these are the things we often see. We see a lack of accessible resources on the units. So Dr. Glowitz talked about making those hand hygiene, alcohol-based hand rubs available outside and inside the rooms. It's the same for PPE, and that's a leadership thing. If you think that PPE is accessible because it's down the hall where you first have to go up the hall to get a key and then down the hall and then unlock the door and then go behind 2 or 3 doors to get PPE, it's not. So I would reevaluate that. A lack of compliance with PPE and hand hygiene. We see failure to clean mobile equipment, failure to distinguish what is clean from what is dirty. We see storage of supplies in the splash zone. A lot of these bugs that we're talking about love the water, and they sort of live down in there in that biofilm, and they splash out onto things, and we take it into the patients. One of the most concerning things I saw in a splash zone recently was an ambu bag. So an ambu bag, so now it's in the splash zone. We splash stuff up onto an ambu bag, and then, if needed, we ambu uh, uh, those organisms into someone's lung. Well, that's not cool. And then lack of environmental cleaning. So leadership messaging, I can't express enough how important leadership messaging is. I can't stress enough how important education to staff, allowing your staff to come to boot camp like this. I hope this really helps them, and that they can educate their staff when they go back. Um, our HAI program, again, we exist to help, and we're here to help you. And then communication on transfer, obviously within the facility, outside the facility, always make sure you're communicating your transfers. Just about out of time, but one of the things we do, knowing is half the battle, okay? So knowing that you have these organisms either infected or colonized in your building, that helps you to lock it down so it doesn't spread. So what we offer is a point prevalence survey, certainly in outbreaks, to see, is this spreading? And so we will send you swabs from our regional lab, which is in Wisconsin, by the way. And uh, and so we'll send you swabs. You'll swab the patient population that we all determine that would need that, and then we'll send back to see if this is colonized in any individuals, and then retest if necessary, and make lasting changes in response to what's known. So companies coming, we would love to visit. We would love to help you out. We are the type of company, we're non-regulatory, and we're the kind of people that you want us to find things, because when we find gaps and we find opportunities for improvement, we can help you improve. And that's why we exist, to help you improve, to improve patient care and patient safety. So we could have a response-driven visit or a prevention-driven visit. Either way, we'd love to help you out. Again, we exist 100% to help you. And that's all I have for you. If you have any questions, comments, or snide remarks, um, I'd be happy to hear from you.
So I think we have time for maybe one or two quick questions, and then the other ones we can go ahead and put in a list and we'll have available for everyone. So one question that we have is around who is to do the notification, the lab or the facility? You're on mute, Chad.
Yeah. I'm assuming you're talking about notification via EPID 250. And so I think probably what that EPID 250 asks, it's probably most appropriate for the infection prevention team, someone on that, to answer that, because the lab's not going to know necessarily an admission date, where they came from, those important things that we're looking for. So the lab will submit the specimens to our state lab, but anything needed to come to us, like the EPID 250, probably someone on the infection prevention team would need to do that. At the
Okay.
same token, a lot of long-term care use maybe a lab at a local hospital, and they might have it worked out that the local hospital infection preventionists, when they get those results or whatever, they fill out the EPID 250. I don't know. Ever how you have it worked out, I don't know. I can't, but ultimately, if that lab was obtained or that specimen was obtained at your facility, you would be responsible for submission. Um, Although you might have other things worked out, like I said, with facilities.
Okay. Is there a contact person for the state of Kentucky for reportable infections? I typically reach out to Andrea Flinchum.
Andrea is, yeah, she heads our program, and certainly, we have created this regional infection prevention program. So when you hear of RIPS, they are our program. They're our regional infection preventionists. So we would ask you always make your first contact with them, because we want you to build relationships with them. We want them to build relationships with you. And so certainly anytime you reach out to a RIP, if it's about Cioris or an Oxa 23 or something, um, it's going to get back to me. It's going to get back to Andrea. But I think establishing contact with the RIPS would be the way I would go with that.
All right. And then we'll ask just one more question. And then, like I said, all the questions that we have, we'll put into a document and send to Chad to answer to make sure that they're answered in the correct capacity. And we'll post those to our sites. So one last question: if the resident is colonized with the infection already, and we know, do we still need to report it?
Yeah, there are reporting guidelines, and so what a lot of times you'll see as an example, yeah. So the short answer is yes.
Okay.
But certainly we see organisms come in, and maybe one time it's in a wound, and that person's colonized with an Oxa 23, and you see it in a wound, and the next time you might see it in blood, and the next time you might see it in the urine. So even though they seem similar, we see them in different um, uh, places and at different times. So yeah, those would be please do, yes.
All right, great. Well, thank you very much, Dr. Eldridge, for this wonderful presentation.